Hello everyone. In this class, we'll try to learn about what is pulmonary circulation. Though the capacity of pulmonary vascular bed is significantly less than the capacity of systemic circulation, the same amount of blood passes through pulmonary circulation. Hence, pulmonary vascular bed handles cardiac output in such a way that pressure is not high for the same volume. Systemic circulation is high pressure circulation due to greater resistance offered by the blood vessels of the systemic vascular bed. The pulmonary circulation, on the other hand, is low pressure circulation due to less resistance offered by pulmonary vessels. The total resistance in pulmonary circulation is about one tenth of systemic circulation. The pulmonary arteries branch like that of airways so that each airway branch and arterial branch run parallel to each other. Pulmonary capillaries are large in diameter and have multiple anastomosis. Arrangement of capillaries is such that each alveolus is surrounded by capillary basket. A branch of pulmonary artery divides further into form arterioles that in turn form extensive capillary lattice around a single alveolus, which drains into branch of pulmonary veins. The pulmonary blood vessels with blood in them constitute about 40% of the total weight of the lungs. So this is the diagram showing the alveolar capillary network where the branch of pulmonary artery which surrounds the alveoli and it becomes the pulmonary vein. The functions of pulmonary circulation. It's important for gas exchange. The primary function of the pulmonary circulation is to bring venous blood from different parts of the body in contact with alveoli for exchange of gases, where carbon dioxide is removed from pulmonary capillary into alveoli and oxygen is added from alveoli into the capillary blood. It also serves as a filter. Pulmonary vessels filter thrombi and emboli that originate from venous compartment of the right side of the heart. Endothelial cells of pulmonary vessels release fibrinolytic agents that lyse blood clots, that is thrombi, and thus prevents the entry of these thrombi and emboli into coronary, cerebral, and other important vessels. Also serves metabolic function. Vasoactive hormones are metabolized in the pulmonary circulation. Angiotensin 1 is converted to angiotensin 2 in the lungs by angiotensin converting enzyme located mainly on the surface of pulmonary capillary endothelial cells. Pulmonary endothelial cells inactivate bradykinin, serotonin, and prostaglandins E1, E2, and prostaglandin F2 alpha. Norepinephrine is also inactivated. It also serves as a blood reservoir. About 500 ml of circulating blood is present in the pulmonary circulation at any point of time. Some of the special features of pulmonary circulation are the pulmonary circulation is low pressure, that is a low resistance system, that is mean pulmonary arterial pressure is just 15 millimeters of Hg. The pulmonary artery and its branches have thin walls. There is less smooth muscle in the walls of pulmonary arteries. Due to their thin walls and paucity of smooth muscle, pulmonary arteries are more compliant. Pulmonary arteries are much shorter and wider. Due to their high compliance, pulmonary vessels can accommodate relatively large amount of blood whenever required. Pulmonary arterioles are also thin-walled and contain less smooth muscle. Therefore, ability to constrict is less than thick-walled muscular arterioles of systemic circulation. The pulmonary veins are also thin-walled and highly compliant. The arrangement of pulmonary capillaries is different. The capillaries form lattice in the alveolar wall so that blood flows as a thin sheet. Thus, pulmonary capillaries do not form capillary network. The walls of the pulmonary capillaries are very thin and therefore they collapse if local alveolar pressure exceeds capillary pressure. A continuous and closed column of blood connects the probe end and the left atrium. The wedge pressure reflects left atrial pressure. The pulmonary vascular resistance. The pulmonary vascular resistance is very low, so which is about one tenth of that of systemic vascular resistance. The extremely low resistance is due to two factors. One is pulmonary resistance vessels are thin, short, and wide, and thus they have a very high compliance. The resting vasoconstrictor tone is very low or absent, for which the arterioles are mostly dilated. Then, a unique feature of pulmonary circulation is that the pulmonary vascular resistance falls with increased pulmonary arterial pressure, as occurs in increased cardiac output. The ability uh, to significantly decrease the pulmonary vascular resistance in response to increased pressure is due to two mechanisms. Normally, many capillaries are partially closed in the upper part of the lungs because of the low perfusion pressure. When blood flow increases, the collapsed vessels are opened. This is called as capillary recruitment and is the primary mechanism that accounts for the fall in the pulmonary vascular resistance to increase cardiac output. The second mechanism is capillary distension in response to increased pressure. The physiological significance of the low pulmonary vascular resistance. The decrease in pulmonary vascular resistance with increased cardiac output has three beneficial effects. The decreased resistance decreases the velocity, especially when the blood flow is uh, rather rate is high. This provides adequate time for pulmonary capillary blood to take up oxygen and dispose carbon dioxide. The capillary distension that decreases resistance increases the capillary surface area, which facilitates diffusion of gases along the alveolar capillary membrane. A high capillary pressure can cause pulmonary edema and impair gas exchange. For example, during vigorous exercise, cardiac output increases enormously, that increases blood flow and the pressure in the pulmonary circulation. However, decrease in pulmonary vascular resistance decreases the load on the right ventricle and lowers the capillary pressure that prevents pulmonary edema. Coming to the pulmonary blood flow, there is approximately 500 ml of blood is present in the pulmonary circulation at any given time, which is about 10% of the total circulating blood volume. The distribution of 500 ml of blood is as follows. In pulmonary arteries, about 150 ml; in pulmonary veins, 270 ml; in pulmonary capillaries, about 80 ml. In upright posture, the blood flow increases from apex to the base of the lung. So this difference, that is the lowest blood flow at apex and highest blood flow at the base, is due to the effect of gravity. What are the factors affecting pulmonary blood flow? The factors affecting the pulmonary blood flow are mainly pulmonary vascular resistance, gravity, alveolar pressure, and arterial to venous pressure gradient. Pulmonary vascular resistance is affected mainly by the lung volumes, hormones, and oxygen tension. The lung volumes, the pulmonary capillaries have less structural support, thus, they can be easily distended or collapsed depending on the surrounding pressure. Functionally, the pulmonary vessels are two types: alveolar vessels, that comprises of arterioles, capillaries, and venules, and extra-alveolar vessels. The extra-alveolar vessels are subjected to pleural pressure and alveolar vessels are subjected to alveolar pressure. When there are high lung volumes, at high lung volumes, the pleural pressure is more negative. This increases the transmural pressure, that is the pressure inside the vessel minus pressure outside the vessel in extraalveolar vessels, and vessels are distended. However, increase in the alveolar diameter at high lung volumes decreases the transmural pressure in alveolar vessels, as A result of alveolar vessels are compressed and the pulmonary vascular resistance is increased. Low lung volumes. At low lung volumes, pleural pressure is positive, so which compresses the extra-alveolar vessels. This increases the pulmonary vascular resistance. Thus, pulmonary vascular resistance also increases at low lung volumes. Pulmonary vascular resistance is lowest at functional residual capacity and increases at both higher and lower lung volumes. Some of the hormones serotonin, norepinephrine, histamine, thromboxane A2, and leukotrienes are potent vasoconstrictors. They increase capillary, they increase pulmonary vascular resistance, particularly at low lung volumes when vessels are already compressed. Adenosine, acetylcholine, prostaglandin, and isoproterenol relax smooth muscle of the blood vessel and decrease pulmonary vascular resistance. Even low oxygen tension increases the pulmonary vascular resistance by causing vasoconstriction. The other factors which affects the pulmonary blood flow is gravity. Gravity significantly affects the pulmonary blood flow. Due to the effect of gravity, in upright posture, pulmonary blood flow increases from apex to the base of the lungs. This is because apex of the lungs remain above and base remains below at the level of heart. With 1 centimeter increase in the height above the heart, the hydrostatic pressure falls by 0.74 millimeters of Hg, and with 1 centimeter decrease in the height below the heart, the hydrostatic pressure increases by 0.07 mm of Hg. Thus, pressure in the pulmonary artery at apex, which is about 10 centimeter above the heart, is 7.4 mm of Hg less. The arterial pressure in the lung at various levels are: at the level of heart it is 14 mm of Hg, at the apex of the lung it is 6.6 mm of Hg, that is it is 10 centimeter above, and 7.4 mm Hg less. At the base of the lung it is 17.7 mm of Hg, that is it is 5 centimeter below the heart and 3.4 millimeter uh, Hg more. Gravity influences both arterial and venous pressures. These variation in the pressures are not only influence the blood flow but also the ventilation perfusion ratio. As gravity causes change in the lung perfusion from apex to base, physiologically lung is divided into three zones. Zone 1 is upper zone, zone 2 is middle zone, and zone 3 is lower zone. Effect of alveolar pressure. Alveolar pressure depends on the lung volume. Alteration in the alveolar pressure due to the change in the lung volume changes pulmonary blood flow. Then the difference between the pressure at arterial and venous compartment of the pulmonary circulation determines the rate of blood flow. The arterial to venous pressure gradient is affected by alveolar pressure. How blood to the pulmonary circulation is regulated? The pulmonary blood flow is regulated by active and passive factors. Some of the active factors are neural, hormonal, and chemical mechanisms. Neural regulation, though the pulmonary circulation is richly innervated with sympathetic nerves, pulmonary vessels pulmonary vessels diameter is virtually unaffected by the autonomic nerves in normal conditions. This is because the resting sympathetic tone of pulmonary circulation is almost absent. However, sympathetic stimulation causes mild vasoconstriction and parasympathetic stimulation causes mild vasodilatation. Hormonal regulation uh, is by major vasoconstrictors in the pulmonary bed, which are serotonin, norepinephrine, endothelin, angiotensin, and thromboxane A2 and leukotrienes. They decrease pulmonary blood flow. Vasodilators that increase the blood flow are adenosine, acetylcholine, prostacyclin, bradykinin, and nitric oxide. The chemical regulation is mainly by the hypoxemia or the alveolar hypoxia, which causes vasoconstriction of the small pulmonary arteries. In contrast, hypoxia in systemic circulation and other parts of the body produces vasodilatation. It is proposed that hypoxia directly causes contraction of the pulmonary vascular smooth muscles. The probable mechanism is that hypoxia inhibits potassium channels that depolarize the muscle cells. This opens the voltage gated calcium channels. The influx of calcium causes vasoconstriction. The hypoxia induced vasoconstriction is accentuated by high carbon dioxide and low blood pH. Passive factors that regulate pulmonary blood flow are cardiac output, gravity, and lung volumes. Increasing the cardiac output increases the pulmonary blood flow. Okay. So, so here are some of the vasoconstrictors and vasodilators which are going to affect uh, the pulmonary blood flow. Okay, so as we have discussed previously, filtration across the pulmonary capillaries. Filtration of fluid across capillary walls in the pulmonary circulation is governed by Starling forces, as occurs in systemic circulation. In addition to hydrostatic and osmotic pressure gradients, two more additional factors play a role in the fluid transfer across pulmonary capillaries. These factors are surface tension and alveolar pressure. The alveolar surface tension pulls the alveolar wall inward, that facilitates the alveolar collapse, that decreases the interstitial pressure and therefore draws fluid into the interstitial space, that is, favors filtration. Whereas alveolar pressure uh, compresses the interstitial space and increases the interstitial pressure, opposes the filtration. The hydrostatic pressure in the pulmonary capillary is low, so which is about 8 to 10 mm of Hg, as it is significantly less than the oncotic pressure, which is around 25 mm Hg. This favors the net absorption of fluid from interstitial space into the capillary blood. The alveolar surface tension favors filtration and counteracts the advantage of low hydrostatic pressure. The net result of which is that small quantity of fluid fluxes out of the capillaries into the interstitial space. The lymphatic system is extensive and well developed in lungs. The lymphatics are mainly located near the terminal bronchioles, which is favorable for them to drain excess of fluid from peribronchial space. Coming to pulmonary edema, the pulmonary edema develops when excess of free fluid accumulates in the interstitial spaces and alveoli. The pulmonary edema is caused by the following mechanisms. First one is increased capillary hydrostatic pressure. This is the commonest cause of pulmonary edema. Most frequently, it results from an abnormally high pulmonary vascular pressure as occurs in mitral stenosis or left heart failure. Then it occurs because of the increased alveolar surface tension. High surface tension lowers the interstitial hydrostatic pressure that favors filtration. Decreased surfactant synthesis increases the surface tension and causes pulmonary edema as occurs in ARDS. Then decreased oncotic pressure, the plasma colloid osmotic pressure decreases as is seen in hypoproteinemia, occurs in starvation. Even increased capillary permeability, this is a major cause of pulmonary edema. Increased capillary permeability occurs with pulmonary vascular injury as it occurs in the oxidant damage, that is example oxygen therapy, ozone toxicity, like inflammatory reactions by the actions of some endotoxins, and neurogenic shock, that is a head injury, as a major cause of pulmonary edema. Physiological basis of treatment of pulmonary edema. The aim of the treatment of pulmonary edema is to mainly reduce the pulmonary capillary hydrostatic pressure. So this is mainly achieved by the diuretics that decrease the blood volume, digitalis that increase the left ventricular function, and so which is nothing but usually the inability of the left ventricle to pump blood effectively produces the pulmonary edema and vasodilators that cause relaxation of the systemic vessels. In drowning, freshwater drowning, though the aspiration of water occurs into the lungs, death does not occur due to the pulmonary edema. That death in the drowning is usually due to the ventricular fibrillation. The aspirated water enters the alveoli and from there into the pulmonary capillary blood because of the flow of lower capillary hydrostatic pressure and high oncotic pressure. Entry of water into blood dilutes the plasma and produces the hypotonic environment for red cells. This results in hemolysis. Hemolysis in turn causes hyperkalemia and hyponatremia. Ventricular fibrillation occurs due to the hyperkalemia and hypoxemia. In saltwater drowning, the aspirated water is hypertonic due to the high sodium and chloride content of the seawater. The hypotonic fluid in alveoli produces pulmonary edema, and the cause of death in seawater uh, drowning is mainly because of the asphyxia. So that is all about, uh, in brief, about pulmonary ventilation. Thank you.